Hello, everyone, and welcome to our webinar on understanding opportunities and barriers to launching social care initiatives in Medicare Advantage Plans. This is Caroline Fichtenberg from Siren at UCSF. We're excited to have you all on the line today, and you're going to be hearing today about some very interesting new research on the impact of new federal flexibilities for Medicare Advantage Plans. Our speakers today, we have three exciting speakers, and our session today is going to be moderated as well. Our moderator today is Laura Skopak, who is a Senior Research Associate at the Urban Institute, where her research focuses on Medicare, Medicaid, and the social determinants of health. Our three speakers include David Myers, who's a doctoral candidate in health services research at the Brown University School of Public Health. His primary research interest is Medicare Advantage policy. Kelly Thomas, our second speaker, is an associate professor of health services policy and practice at Brown University and a research health science specialist at the Providence VA Medical Center on innovation for long-term services and supports. Her research focuses on identifying ways to improve the quality of life of older adults needing long-term services and supports through applied health services research. And we're also going to hear from Laura Shields-Seaman, who was a 2018-2019 Commonwealth Fund Harkness Fellow in Healthcare Policy and Practice and a visiting scholar at the University of California, San Francisco. Her research focuses on health and social care integration and clinical and policy approaches to addressing adverse social determinants of health. So without further ado, I'm going to turn it over to David Myers, although actually I am going to say a few things first. Please use the chat function to send us any questions you have for our speakers. We're going to be doing questions at the end, and we'll do them through the chat function. So please send questions through the chat function. Other than that, I'm now going to turn it over to David.
Hello, everybody. I'm going to get us started off by talking about some of our recent work looking at the adoption of new supplemental benefits in 2019 and 2020 by Medicare Advantage Plans. I have no conflicts of interest to disclose, and I'd like to thank my co-authors in this work. So as many of you might know, Medicare Advantage, one of the ways it differs from traditional Medicare is that MA plans can offer supplemental benefits that aren't traditionally offered in the Medicare program. Previously, these benefits needed to directly prevent or treat illnesses, and daily maintenance activities were not allowed. However, in 2018, CMS released new guidance to plans that as of 2019, plans can now compensate for physical impairments, act to ameliorate the functional and psychological impact of injuries or health conditions, or reduce avoidable emergency and healthcare utilization to expand the types of benefits that these plans can offer. They gave some examples of new benefits that plans could start to include as of 2019, and these included things like adult daycare, caregiver supports, home and bathroom safety modifications, palliative care services, and other benefits for their enrollees. In 2020, these benefits were actually expanded even further coming up this year as a result of the Creating High-Quality Results and Outcomes Necessary to Improve Chronic Care Act, or just the Chronic Care Act for short. And what the Chronic Care Act allowed that was detailed to plans in 2019 is that starting in 2020, plans can design additional supplemental benefits for those enrollees who they deem as chronically ill. So not every enrollee needs to get these benefits, but for those who are chronically ill by the plan's definition, new benefits can be offered. So CMS gave some examples of what these benefits can look like, and they include things like meal programs, non-emergency transportation services, pest control, air conditioning, and any other benefits to address social need as long as such items and services have a reasonable expectation of improving or maintaining the health or overall function of an individual as it relates to their chronic condition or illness. So it's quite a broad expansion of what can be offered for these chronically ill enrollees. So we used data that was released by CMS publicly in 2019 and for 2020 on the types of benefits that plans offered, because we wanted to get a sense of how many plans are offering these new benefits and what types of plans are choosing to offer them. In 2019, we found that overall the adoption of these new benefits was relatively low. The type of benefit that was adopted the most, about 429 plans, accounting for 17% of enrollees, offered some type of caregiver support service. But otherwise, things like adult daycare, home-based safety modifications, and other benefits, very few plans decided to offer them for their enrollees in 2019. Looking at these same benefits, starting this coming year in 2020, a lot of plans actually expanded this. With another year under their belt, the number of plans offering things like adult daycare, safety modifications, in-home support services increased quite a bit from one year to the next. So with an additional year, it seemed like plans were more willing to offer additional benefits or more able to deliver on these new benefits. Looking at the two new benefits that were offered in 2020, specifically the ones that CMS detailed as potential benefits, we found that about 64 plans that will probably be offered to about 1.4% of Medicare Advantage enrollees are offering some type of new meal program. Many plans are starting to actually offer non-medical transportation services. Interestingly, about 11% of plans we found are starting to offer rideshare services, so that's using things like Uber or Lyft to bring their enrollees to appointments. But we also found that that no standard Medicare Advantage plans offered pest control or air quality control benefits, which were two of the other benefits that CMS explicitly said were possible. When looking at the types of plans that tended to offer any new benefit, we found that HMO, Health Maintenance Organization plans, larger plans, those that are higher star rated in Medicare Advantage star ratings, and older plans tended to more often decide to offer one of these new benefits in 2019 and in 2020. So, in conclusion, we found overall that the adoption of these new benefits was relatively slow in 2019 and in 2020. However, with an additional year in 2020, this coming benefit year, we started to see that many more of these 2019 new benefits are starting to get offered. So it may take plans additional time to be able to incorporate these into their benefit packages. And we've also found that larger, higher-rated plans tend to offer these new benefits at greater rates. And I think we can get into some of the reasons for why that might come out in some of the subsequent discussion. So thank you very much. And I'll now hand it off to Dr. Callie Thomas to talk about some of our qualitative results.
Thank you, David. Today I'll be sharing some results from interviews that we've conducted with Medicare Advantage plans over the last year. As David said, I have no commercial relationships to disclose. I'd like to acknowledge my co-authors listed on the slide, as well as funding that we received from Meals on Wheels America, the Nonprofit Finance Fund, and the U.S. Department of Veterans Affairs in support of this work. The objectives of this research endeavor that we undertook was to understand Medicare Advantage plan representatives' perspectives on the importance of addressing members' social needs and their responses to the passage of the Chronic Care Act of 2018. To do this, we conducted semi-structured qualitative interviews with plan representatives from 17 plans across the country. These interviews were conducted between July and October of 2018. We recorded the interviews, coded them, and qualitatively analyzed them using modified content analysis in an effort to understand overarching themes that were observed across the interviews. Our study sample included 38 upper management personnel from 17 Medicare Advantage plans who collectively enrolled 65% of all Medicare Advantage members nationally in 2018. Importantly, the representatives from the plans to whom we spoke varied in terms of their geographic coverage, in their 5-star quality ratings, the length of time that they've been providing Medicare Advantage, as well as their enrollment. And what we found was that MA plan participants recognize the importance of addressing members' social needs for improving both member health and the larger healthcare system. Participants also highlighted how addressing members' social needs enables their members to remain in the community and reduce their healthcare costs. And when describing this priority, a representative from one plan said, "We really try to keep people in the community as much as possible. And that means providing everything from transportation to home-delivered meals to durable medical equipment and things that will make it possible to keep people in their home. We feel pretty strongly that if we're able to maintain people in the community and address their social determinants, that their health care costs go down. So it's a pretty high priority." Participants also described social determinants of health as an increasingly discussed topic in Medicare Advantage, especially in response to legislative and policy changes like chronic. A representative quote from one participant said, "Social determinants of health certainly is becoming much more of an area of focus for us. You can't go to any type of event where healthcare improvements being discussed in the state or a national event or whatever, or even some of our own internal meetings, and the phrase social determinants of health comes up, because it's clear that it plays a big role in people's health." The second main finding concerned whether and how to address members' social needs. While participants to whom we spoke from MA plans consistently discussed the importance of addressing member social needs, they offered divergent perspectives on whether and how the plan should do so. While some of the participants that we spoke to were excited about offering new benefits or expanding existing services to address social determinants of health, others questioned the appropriateness, if you will, of expanding their purview to include non-medical care. And so given these differences in perspectives, there were two distinct methods of providing services to address social needs that emerged. The first that we heard about was supporting community-based organizations and referring members to these organizations to receive needed services. And the second approach was to address social needs through formal benefit design, specifically a supplemental benefit. So as I alluded to, some participants questioned whether it was the plan's responsibility to address members' social needs. A representative from one Medicare Advantage plan said, "That's the conundrum I think we're in terms of what degree do we really want to innovate and get into lines of business that really are best served by providers or communities at large. It's a fundamental question that I think we're still working through." Some participants mentioned the importance of a collaborative effort by plans, community agencies, and other stakeholders to fully address members' needs. And these participants preferred to refer members to community-based organizations and support these community-based agencies rather than offering a formal benefit. For example, one participant who recognized the strength of organizations in the community described in this quote, developing a program that aggregates community resources that can be used by care managers to identify services and make referrals for members. This person said, "Increasingly we're looking at care management programs that leverage community resources. We have a program that's kind of an aggregator of those services that's made available to our care managers that they can bring to bear when they're engaging members and find that they have needs that are kind of outside of our benefits." And as I alluded to, other plans discussed investing directly in CBOs through community grants to enable these organizations to provide needed services to members and to help their community partners be sustainable. Participants highlighted being cognizant of not wanting to duplicate these efforts, given the expertise and experience that community-based organizations have in addressing social needs. A quote from a participant said, "These community agencies often have really important long-term relationships with their members. That's something we want to enable and empower them to continue to do without necessarily having to rely on their health plan to do so. We're investing close to $250,000 in addressing social needs through community grants because we believe our communities are best positioned to be able to address their own needs. They're closest to it." With the increased flexibility for benefit design that was made possible with the passage of the Chronic Care Act, some participants discussed their motivation to introduce a new benefit. So we had plans that expressed interest in doing this. And these participants noted not only the value of offering a benefit to increasing members' health and their ability to remain in the community, but it also allowed them to target specific subgroups of members. A plan participant from one organization said, "One challenge that MA organizations have had for years has been even if we've identified specific populations that have the need for specific programs, the requirement has always been that we provide them regardless of need to everybody evenly. In future years, we'll have the ability to develop programs and benefits that are more targeted than maybe has been the case in the past." Some participants mentioned that offering a new supplemental benefit to address member social needs is a way to meet consumers' desires and expectations, and this might be a way that could allow them to be more competitive in the marketplace and increase their membership. One participant said, "I'm looking to grow my membership. We're a for-profit company, so the other thing that I'm looking at is what is going to be the things that are going to resonate out in the marketplace that people want to see and want to have." For plans that were looking to create a formal supplemental benefit, many mentioned being reliant on community-based organizations to provide these services. And in thinking about who would be good business partners, participants expressed a desire to work with community-based organizations that had an evidence of success. One participant said, "The more evidence they have that their solution creates the outcomes to solve the problem that we have, the better. It's proof points we're interested in. Quality of life, clinical outcomes, and more of the business financial result." So if they, community-based organizations, have that trifecta, that's great. If they have one or two of them, then that's okay, and we kind of make a case-by-case decision. We want to know that there are health outcomes, and we want to know if there are business or financial outcomes. Some participants also who are looking to offer a benefit are also highlighted the importance of selecting a partner who had the ability to scale services to reach all of a plan's members. One participant said, "With CBOs, there's such variability in their ability to execute at a high level. They might be really, really good at doing meals in a very confined geography for a very specific population, but they've not really been able to take that to a higher level. So if they haven't really demonstrated their ability to do that, we'd be hesitant to put all of our marbles in that box." And finally, participants described the need to work with community-based organizations who have an understanding of MA compliance and regulatory issues. One participant said, "Recognizing that we're regulated by CMS. So anytime any vendor would be coming to us and wanting to have the opportunity to interact with our members in some capacity, they'd have to sort of have a baseline knowledge of CMS compliance requirements." So in conclusion, our study observed that MA plans, the participants from MA plans indicate that social needs are important and should be addressed. However, their approaches to doing that are distinctly different. Some plans are interested in creating new supplemental benefits and taking advantage of the flexibility offered by the Chronic Care Act, while others prefer to support community-based organizations to address members' needs. We also heard from participants the variety of factors and characteristics that they're looking for in community-based organizations that would make them appealing partners in offering these benefits. And their takeaway from this study, and further confirmed by the work that David has been doing, is that given these different perspectives and approaches to addressing member social needs, the need for more evidence, we believe that changes in MA plans benefit packages in response to the Chronic Care Act will likely be modest initially. Thank you. Now I'd like to pass it over to Laura Shields-Zeman, who will be sharing additional work conducted with MA plans around addressing member social needs.
Thanks, Callie. So at UCSF, we did something very similar to Callie's team. The difference is, and the reason why we thought these would be complementary presentations, is because we did our interviews with MA plans a bit later, after they had already submitted their bid for 2020 or were just about to, and were reflecting on the decisions that they made for 2020. So we were interested in learning whether Medicare Advantage plans were using the additional flexibility offered by CMS to direct supplemental benefits towards supports that address health-related social needs. So this includes meal programs to address food insecurity, housing supports, social isolation programs, or transportation to address challenges in getting to appointments. So more specifically, we were interested in learning whether this flexibility offered was too premature for plans or whether they would take advantage of this greater flexibility, as well as what shaped their decisions to offer new or expanded benefits that address health-related social needs. So to tell you a little bit about how we selected plans to interview, we took a random sample of nationally representative plans, making sure that we had broad coverage. We also wanted to make sure that we had some special needs plans represented, as well as both for-profit and not-for-profit plans. And we've interviewed 14 plans covering about 25 individual members from across these Medicare Advantage plans. Within each of the plans we spoke to a member of the executive leadership team as well as somebody from the clinical or social determinant side that could speak both to the content of the bids as well as plan priorities related to social determinants of health. So in terms of what we found, the first theme that we identified were the reasons that plans were addressing social determinants of health. And one of the main reasons was that it fit within their organizational mission, and plans were having an opportunity to now offer benefits that tackle adverse social determinants in their Medicare Advantage products. So for plans that had other products available, like Medicaid products, they had already been thinking about the health-related social needs of their members for some time already, and they might have already had benefits in this regard. Now they had an opportunity to bring this into their Medicare products, and were exploring benefits design and offerings that fit into this new framework. So though the mission-driven work was the basis for why many plans were getting into this, many spoke about the importance of this being a sound financial investment. In some instances, even though people were doing this work and expanding benefits, they weren't sure the financial investment was going to pay off, even though they hoped it would. So one plan actually told us it gives actuaries heartburn. Nevertheless, they were piloting or offering new benefits because they were mission-driven. Another plan told us it's a tight time frame for a plan to get a real understanding of the impact of the benefits. So I sort of took a chance and pushed the team to expand it. So this was another example that even without clear evidence or return on investment information, plans were still doing this work. And this, of course, limited the amount of investment they could do at this point, but the mission orientation was still driving them in figuring it out. A second theme and a key message we heard across our interviews were the evidence gaps, which hindered a plan's ability to estimate the impact of a new or expanded benefit offering. One plan told us, most research has been about correlations between the social determinants of health and health outcomes. What's missing is evidence around causation. If you address food insecurity, what happens to cost of care, hospital admissions, etc., the evidence is lacking, frankly. Two plans mentioned that the evidence was shaky to the extent that they decided not to offer new or expanded benefits related to social determinants of health in 2020, despite having an executive leadership team motivated to do so. So in terms of what are Medicare Advantage plans offering in 2020 and what changes are they planning? In our interviews, we heard that plans are focused largely on three adverse social determinants: food insecurity, transportation challenges, and social isolation. Most of the plans we spoke to are piloting or will start piloting in 2020 some of these programs and evaluate the return on investment as well as the health impacts of these new or expanded benefit offerings. We heard from a few plans that interest in tackling adverse social determinants has increased, but they actually had not decided to change benefit offerings for 2020. So as an example, one plan told us that they had previously offered a benefit addressing food insecurity, which had low uptake among members. So in 2020, rather than offering this benefit, they instead reinvested resources into lowering their premiums. And they told us, I know that's not as sizzly as adding a meal benefit, but that's literal money back in our members' pockets, and we consider that really valuable. So in their view, this was seen as important for addressing affordability and reducing the financial constraints of their members. We also found that plans are interested but slow in using the greater flexibility offered by CMS to offer supplemental benefits that address health-related social needs. Plans that decided not to change their offerings for 2020 mentioned that the decisions were related to unclear evidence of return on investment or due to challenges in resource allocation. Plans were also hoping that more data would come out in the next few years. As indicated by this quote, we started looking at it from a financial perspective, and there just wasn't a whole lot of data out there. We just weren't seeing many people take us up on this benefit. In terms of future directions, one benefit of these recent federal policy changes has been the start of a new dialogue on the role of Medicare Advantage in addressing social needs of their members. As one plan told us, just because we aren't offering it in 2020 doesn't mean we're not having ongoing conversations. This flexibility from CMS is creating a whole new conversation we've never been able to take before. So we're all running down this road, not sure where it's going to lead us, but very interested in doing the right thing. So to summarize, this opportunity with greater flexibility fits within what Medicare Advantage plans we spoke to want to do and fits with the population that they're serving. For many plans we spoke to, the new flexibility to address health-related social needs fits with their mission statements in treating the whole person. So the three main takeaways we had were that plans welcome flexibility from CMS. Second, there's some hesitation about the amount and quality of evidence available as well as the financial return from these kind of programs, and more implementation experience is needed. And third, people are really looking to next year to better understand what kinds of programs are going to be the most effective. And we think there's value in seeing how these benefit offerings change in the coming years and tracking those changes together. There are also availability of some tools, like for instance, the Commonwealth Fund Return on Investment Calculator for Social Determinants of Health, which are also available and might be able and useful for plans in discussing future offerings. That's it for me. Thank you for your attention, and I'll pass it on to Laura Skopek to moderate the question and answer part of this webinar.
Great, thank you for those great presentations. Before I get to the Q&A, I just want to provide a little bit of additional context to tie together what we've heard so far. But while I'm doing that, please go ahead and submit any questions to the chat box, and we'll get to those in just a minute. So the Urban Institute also did a qualitative study of these issues that overlapped significantly with the studies you just heard. But there are a few additional themes I'd like to highlight. First, MA plans have to pay for these new benefits out of their rebate dollars. In 2019, rebate dollars averaged $107 per person per month. It's not a tiny amount of money, but it's certainly not going to make a huge dent in housing or long-term care needs. Also, plans were already using those rebate dollars for supplemental benefits like dental, vision, gym memberships, and copay cards. They were not given any additional funds when these new benefit opportunities arose. And some plans expressed to us that those more traditional supplemental benefits like dental were more important for marketing and for increasing enrollment. And they were concerned about having to maybe reduce those benefits to add these new benefits that are untested. We also heard from some of our interviewees that they were concerned the new supplemental benefits because they needed to target them based on conditions would be hard to market accurately, to be clear with people that this benefit's only available if you have certain conditions. And also, we didn't hear this directly in interviews, but I would add that there might not be a lot of financial upside to a Medicare Advantage plan in attracting people who have, for example, significant housing instability or other complex issues that aren't going to be reimbursed through risk adjustment. The last thing I want to highlight is that it's important to keep in mind that MA plan availability and rebates vary a lot geographically. So these types of supplemental benefits will vary a lot geographically too. In addition, MA has grown substantially over the last several years, but 2/3 of all enrollees are still in traditional Medicare, which has no opportunities to access these benefits. So there's just going to be a limited applicability of these benefits across geographies and within the Medicare program. I see some clarifying questions in the chat box. I'm going to start with those because I think we can knock those out pretty quickly. So first few are for David. Do you have any idea what happened? There was a large drop in caregiver support in 2020 versus 2019 and plans offering caregiver support.
Yes, so that struck us too, that there was such a decrease, and we did look into this, and it's a difference of one company that in 2019 had offered caregiver supports across most of their offered plans in 2019, and that same company decreased drastically the number of plans that they were going to offer those caregiver support benefits in. So it's primarily from one place just shrinking their offerings as opposed to sort of a national trend in those benefits going downward.
And then also on that slide, are the numbers of enrollees in both years based on 2019 enrollment, or is it yes, for 2020 is the enrollment estimate based on 2019 enrollment?
Yes, yeah. So since open enrollment is still open right now, we don't know exactly what the number of enrollees are that are going to choose all of these plans in 2020. And there are also new plans that we don't have any enrollment numbers at all for. So I would say that these enrollment numbers are sort of a limited picture from 2019. The enrollment numbers in 2019 are sort of the number of people who got access to these benefits.
Great. And then this is probably for David or Callie. Was there a definition that you offered to plans for meals in 2020? Are they sort of prepared meals like Meals on Wheels, or could they be just boxed ingredients?
Yeah, so as far as on the quantitative side, in the benefits data, it's not readily apparent when one type of meal is, when a boxed meal versus a meal delivery is used, one versus the other. Typically, I believe both are possible as options under this, but that's not something that we can see on the quantitative side what a plan is choosing to do. It's more of a checkbox that it's something they're choosing to offer.
Okay, a question for Callie and Laura. From your interviews, how are MA plans already addressing, that are already taking up these benefits, looking at return on investments? What data are they reviewing to determine if the investments are making a positive impact? Are they looking at outcomes, et cetera?
Sure. So this is Callie. I'll start with that one. We did hear from some plans about the pilots that they're undertaking, the data that they're collecting, the challenges in sharing and obtaining data with community-based organizations. It was not a specific question that we asked about, so I can't speak in generalizable terms as to for these plans, but it did come up that there are plans that are digging down. They're looking at the financial data, the utilization data to understand where and how they want to move forward.
Hi, and this is Laura. I can just add to that. Similarly, the plans that we interviewed, the majority of them are piloting new or expanded benefits, and they did mention that they had internal research teams evaluating both the financial aspects of the benefit as well as service utilization outcomes. But indeed, it wasn't a specific question from us in terms of what outcomes they looked at.
And did any of the plans either of you talk to analyze how many members were taking up these new benefits and perhaps why or why not?
So this is Callie. At the time that we conducted our interviews, the benefits had not yet been, the new supplemental benefits that were allowable through chronic, specifically the SSCBIs, they were not yet out in the field, so that was not something that they could speak to.
And from my side, some of the plans that we spoke to were able to evaluate the implementation of some benefits related to food or meal programs, and they were not able to comment concretely on why the uptake was not as high as they expected. They weren't sure if that was related to providers or marketing or another reason of the plan under the plan's purview, but they were shaping based on the uptake numbers that they were getting, what they were going to offer in the following year.
We have a couple of questions about work with community-based organizations. First for Callie, did any plans indicate that they were contracting with community-based organizations to provide these services, or was this primarily just community grants?
Sure. So we did hear that there were some plans that were contracting with community-based organizations for some of the work that they were doing outside of formal supplemental benefits, so through these pilots and through these initiatives that they were funding with administrative dollars. And we also heard that plans who are considering offering a formal benefit would be doing so in partnership and through contracting with community-based organizations. So I would say yes, that there are plans that definitely, to whom we spoke, that were definitely engaging and contracting formally with these community-based organizations, in addition to plans that were supporting and working with them in less formal, if you will, arrangements.
And I think for either Callie or Laura, did you get any sense of how Medicare Advantage plans are reaching out to these community-based organizations? We've had several people that work for community-based organizations, right into the chat box saying, how do I get connected to health plans? How do we work with plans and let them know about our services?
Sure. So this is Callie. So the interaction with community-based organizations, just given the nature of our particular study, was one that we did ask, we did focus on. And one of the things that we heard from plans was that they wanted community-based organizations, or that a number of these plans had community-based organizations that approached them. I can recall one participant saying on a daily basis they heard from organizations and vendors about the services and products that they offered. And so to the CBOs that representatives that are on the line, I think part of our findings that might resonate specifically with your organizations was that when you come to the table and you have those conversations, come with proof points, come with an understanding of the Medicare Advantage policy landscape and the space and the regulatory requirements that these agencies and organizations work under through CMS, as well as tying the outcomes that you can produce to outcomes that are meaningful for the plan as they relate to their HEDIS ratings, their STAR ratings, consumer or member satisfaction, as well as the utilization measures that they care about.
And before we switch topics for a minute, one last question on CBOs. Can either of you comment on the factors that might influence MA plan to use a community-based organization versus another type of vendor, like a for-profit vendor, specifically for transportation and meal delivery?
Sure. So I heard, I can't say I recall any findings specific to the type of community-based organization and their profit status. But and as I said in the presentation, a lot of the choice around which community-based organizations to work with had to deal with the evidence, the data that they could present, their scalability, their consumer satisfaction. I didn't offer a specific quote around that, but we did hear from plans that they want to work with vendors or CBOs that have a good reputation and that will meet their members' needs because their complaints goes into the STAR rating, and then relatedly, we heard about plans not wanting to build out these services themselves. So they want to work with vendors, or they themselves don't want to become a transportation vendor, but they'd rather support and work with these organizations that have a footprint already in the community.
Hi, and this is Laura. Just to add to that, we also didn't hear in our interviews specificities about whether it was a vendor or a CBO or a for-profit company, but we did indeed hear that the data that CBOs were able to provide was important, and also how closely connected they were to the specific communities and needs that were served by the MA plan's coverage area. And we also heard, especially for transportation, that plans were not interested in them becoming or moderating transportation logistics and processes themselves, that they would prefer to partner with a vendor or CBO that offer this on a reliable basis and that has a track record of showing that.
And I will say in the Urban Institute interviews, we did hear that it might be easier to contract with so if you're a national plan, you might have an easier time contracting with Mom's Meals, which is national, but for profit, than with all of the individual local Meals on Wheels programs. So I think that is maybe a consideration for some plans. We have a few questions here about targeting. Did any of the plans mention how they were targeting benefits? Were they only available for certain clinical or functional needs?
Laura, do you want to speak to that first?
Sure, I can start. We heard from a few plans that several of the programs related to meals that they were piloting or starting to pilot were specifically for certain patient groups. So that might be those with type 2 diabetes and that had certain limitations in daily functioning or activities of daily living. We also heard a few plans talk about criteria related to behavioral health if it was a program that was related to social isolation. So those were two instances that I can think of that we heard about. Kelly, maybe you want to continue?
Sure. Yeah. So we necessarily, we didn't ask specifically around what benefits they're considering offering and to whom. But one thing that I was, that did strike me from the interviews that we did have was the number of plans that are collecting and have additional data that they're I don't know if I want to say mining, but that they're really combing through and looking at deeply and thoughtfully around who could be best served by these benefits. And so that, so that was one thing that just struck me was the amount of information and the thought that these plans were giving as to the different configurations of benefits and members that they could target for these benefits.
I would also just briefly add that I think this points to one of the challenges in sort of understanding a lot of the benefits data is that while we know if a plan sort of checked off that they'd like to offer one of these benefits or that it is being offered in a given benefit year, there's no other information aside from that checkbox or maybe a short text field. So it's very challenging on sort of a national level to look at what's going on in the space and if these benefits are being targeted to certain types of groups. That's just something that's still a black box that we don't really, or we're not able to see unless you sort of work directly with plans who collect that information.
Another question related to targeting is that Medicare and the Medicare Advantage program tend to favor services that are provided by individual practitioners to individual patients and are time limited. A questioner says this would seem to exclude ongoing social benefits like exercise and dance classes for people with Parkinson's disease. Was that your impression when you were interviewing plans that they were offering sort of time-limited benefits for individual patients? Or did you hear anything about sort of ongoing group classes?
Hi, this is Laura. I can say that we didn't ask specifically about this in our interviews, but some of the plans we interviewed did speak about group wellness or fitness benefits in addition to some of the individually specific benefits that they talked about offering or were already offering.
I would also add that in the guidance from CMS is that traditionally before this new flexibility in 2019, a lot of the requirements around these supplemental benefits were that they would be short-term in nature, and that is one of sort of the flexibilities that's talked about in these guidances, the guidance letters that have been sent to plans, is the ability for something to be more recurring and to address a more chronic long-term issue with many of these types of benefits. So while I don't have a sense of if these benefits are short-term or if they are long-term, it is a new ability for plans to be able to offer these benefits in the more long-term, which wasn't something that was previously permitted.
David, another, I think, more technical question on your slides. Do you have any examples of the types of caregiver supports plans were offering?
Yeah, so a few of the types of categories or types of benefits that we classified as caregiver supports included things like counseling services for caregivers, training services for caregivers, as well as things like respite care, were a few of the examples that we saw sort of come up for the caregivers. But again, we're very limited in that for any of these benefits, plans typically provide, I think they only have 30 characters to provide what we're looking at, so we don't have many more explicit details of what goes into that aside from sort of what the category is called. What those sort of trainings might include, that's not something that is easy to tell from the plan benefits data.
Question for Callie. For those plans that are choosing to support community-based organizations rather than offering the supplemental benefits, do you have any sense of the level of support that they're providing in dollar terms?
Sure. So we heard, I gave a representative quote from one of the plans. We heard a number of them that mentioned investing financially in community-based organizations, so through grants. We also heard plans say that they like to support community-based organizations and find ways to work with them and help build them up. I don't have specifics around what exactly they were mentioning, but I do know that outside of the study, just anecdotally and experientially, that MA plans and leaders in the healthcare space have been actively involved in a number of trainings for community-based organizations on building their business acumen, advancing the evidence base, as well as working with them on developing systems for transferring information, becoming HIPAA compliant, et cetera. So plans didn't speak to that in our interviews. I'm kind of reaching a little bit there outside of the research, but these are things that are going on in the space.
We have a few questions on the types of plans that are choosing to offer supplemental benefits. The first was, did you see any difference in the way that for-profit versus nonprofit Medicare Advantage plans approach supplemental benefits? That's, I guess, for Callie or Laura.
Sure, I can start with that. We didn't actually see that many differences between for-profit and not-for-profit plans in our interviews. We did notice that the special needs plans had a lot more experience and thought in considering how to address the health-related social needs of their members, but that didn't seem to differ between for-profit and not-for-profit plans.
And this is Callie. Relatedly, in the qualitative interviews that we did collect, we had these MA plan organization characteristics, and we didn't identify any distinct themes on the basis of quality or for-profit or age. So that didn't come through in the interviews. And David, perhaps you want to speak to the benefits that were offered and the differences there.
Yeah, so on the quantitative side, as far as the different types of plans, typically we did see that for-profit plans were more often offered these benefits than nonprofit ones, but it wasn't sort of an adjusted analysis, so a lot of that could be because we also saw big national companies were more likely to offer these benefits. So some of it could be that some of the big national companies are also the for-profit ones. But I believe in 2020, there was sort of less of a difference between them. We saw in 2019, really most of the plans that offered new benefits were for-profit. In 2020, it's a little bit closer to one another.
And did plans vary their benefit offerings geographically? For example, even a national plan, were they offering these new benefits only in certain areas?
Yeah, so we did try to look into this as best as we could. It is difficult to sort of tell sometimes. There is service area information for where plans are offered, but sometimes it can be challenging to understand really what parts of the country the benefits are being offered in. Typically we found that at least for the 2019 benefits where we looked at this, plans in New England typically had higher rates of supplemental benefits than in other parts of the country. The South Atlantic also had somewhat higher rates, with fewer sort of plans in the Middle Atlantic and sort of the Midwest had fewer supplemental benefits offered in their plans. But again, it's kind of challenging to tell quantitatively from the data exactly where all these plans are being offered. And I think what sort of came out in some of the interviewing, and I think Callie can probably speak to it more, is that some of the plans, at least in their first couple years, were thinking about testing these benefits in specific areas, maybe as a trial before expanding them sort of more nationally.
Yeah, that's a great point, David. And in fact, we did hear that from from plans in mentioning, when I mentioned the pilot work and the experimental offerings that they were doing. Some mentioned that they preferred to start small before rolling it out to all of their, particularly the larger national plans, before rolling it out to all of their geographic areas, to work with trusted partners in those local geographies, see if they can make the business case before rolling it out across their membership.
And this is Laura. Just to add to that, we found exactly the same thing. So most plans we spoke to that were experimenting with new benefits were piloting them in very select counties. But a few plans we did speak to offered the new benefits to all members. So that was also something that surprised us. About a third of plans that we spoke to that were offering new benefits were making them available to all members right away.
We have a couple questions about data sharing between community-based organizations and Medicare Advantage plans and research that might come out of these supplemental benefits. So speaking to the lack of data available for analysis, is that due to the lack of tracking of the data, that it's not collected at all, or is it due to the inability to access data across different systems and share data across community-based organizations and plans?
So this is Callie. I actually, from the interviews that we collected, I would say it's both. So we heard MA plan representatives talk about how CBOs approach them with data on outputs. So to use the meal example, the number of meals served, the number of people served, the number of meals delivered. But some of these plans said, we want data beyond that. We want to know what your outcomes and your impacts are, not just your outputs. And then relatedly, we heard from plans that some CBOs that with whom they work or that have approached them may have data infrastructure that's outdated or not compliant. There was a plan representative that said, some of the CBOs that they are aware of are still using paper-based systems. And so I think it's a combination of both, not having the data that plans desire as well as the infrastructure to share that information.
We had one person from a CBO noting that the plan that they work with does have some data on return on investment but doesn't want to share it because it's a competitive advantage for them. Did you hear any plans from the Medicare Advantage plans that they would actually publicly share what they're learning in terms of return on investment, or do you expect this all to be internal business data only?
This is Laura. Oh, Callie, sorry.
No, go ahead, Laura.
I was just going to say we didn't hear specifically across any of our interviews that the information on the return on investment would be shared publicly, but maybe we didn't hear that specifically in any of our interviews.
And this is Callie. I will say, likewise, we didn't hear plans saying we're going to make all this information available to the public so we can learn from one another. But we did hear that plans desire that they want to know what each other are doing and what the outcomes are and what works and what doesn't. And so that was one of our implications that came from this research, is that moving forward, CMS may want to consider requirements for these experimental benefits, recognizing that, or these supplemental benefits, recognizing that they might have to reveal what's in their secret sauce, if you will, but in an effort to improve healthcare delivery and move us all forward, we must consider what one another are learning. I think we heard from a number of plans that that's really what they're desiring. Though similar to Laura, I can't remember any raising their hand and saying, we'll share our data with the public so everyone can learn from us.
Maybe I'll just add to that a number of plans that we spoke to were excited about when we talked about a plan for maybe a research agenda going forward to address some of the evidence gaps that came up with specific social needs. They were excited to see what findings would come out from some of the future research, and specifically more implementation research to look at how some of these social risk factors or social needs impact utilization and health outcomes in real-world settings. So that was something that they shared a lot of enthusiasm about across our interviews.
Callie or Laura, did you hear from any plans about how they are contracting with community-based organizations, whether they're doing any shared savings or risk-based contracting, or if it's all fee-for-service and grants?
Sure. So we didn't probe specifically among those that were offering or that were engaged in contracts with CBOs the nature of them. But I will say we did hear from one plan I remember very clearly saying, we want to work with CBOs that have skin in the game. And there was another plan that said some of the CBOs that approach us are more risk averse, but we want to work with those who are willing to take on risk. So I think it's something that that some of the plans that we spoke to are interested in working with CBOs who are willing to participate in this kind of arrangement, though I can't say specifics as to how many of them are doing fee-for-service versus some kind of risk-based contracting.
Okay, we are almost out of time. Maybe one or two more questions before we close up. We had a question about sort of policy. While CMS is offering flexibility to allow plans to offer these benefits, what are the incentives for plans to take this up?
So, I think there aren't, as far as we're aware, there aren't explicit incentives sort of built into the policies around these plans for getting plans to do it. I think some of the ideas that if a plan offers some of these benefits, they may be able to entice more people to enroll in their plan if they're able to communicate that. But there aren't sort of specific incentives in place aside from that plans are also judged on how well they deliver outcomes for their enrollees, how often they're readmitted to the hospital, what their satisfaction is. So potentially these benefits can address those issues, but it's unclear to what extent that's the case so far.
And I could just add to that in our interviews we heard that indeed plans were very much motivated by the potential to reduce admissions or emergency room visits, and that this might be a way to contribute to that. And from a different perspective, we also heard in our interviews that plans really felt like this dialogue about how to address social needs was at the right time, and they really felt this was the right thing to do as a plan, and there was a mission or, as a part of addressing whole person care, that they felt that they really needed to do the right thing and start to explore how to offer benefits to address social needs, where that dialogue wasn't so explicit before.
Great. Well, we're at the hour. This is Caroline again from CSIRO, and I want to thank all of our speakers for these great presentations and for answering all these questions, and also Laura Skopek from Urban Institute for moderating this webinar. As a reminder, the slides and the recording will be available on the Siren website. All of you will receive an email as soon as those are up. Please do give us feedback on this webinar through our survey. You'll get a pop-up on it as soon as you log out of this webinar. And I hope everybody has a great rest of their day. Thanks again so much.
Ladies and gentlemen, this concludes today's call. Thank you for your participation. You may now disconnect.